30 minutes. I'm going to present 3 cases and then turn it over to Erol for the remaining cases. My one case is a little bit thoughtful, maybe hopefully a little bit controversial, and you guys can give me your opinion. The other 2 are just some fun cases that were interesting that I thought would be nice to look at. We have some faculty, Nitin from Mumbai, Peter Khan from down the road at Galveston. Omar. Omar and Gavin Britz from down the road also, and Carlos, who is at MUSC. So, North Carolina, I'm sorry. So let's get started here. Case 1, pretty typical presentation, 65-year-old with a subarachnoid hemorrhage and neurologically doing well, but a little bit sleepy, gets an EVD. And here's her angiogram here. My eyesight's not that good. So this is the ruptured aneurysm here in a 65-year-old with subarachnoid hemorrhage. Any thoughts about management? Nitin, you want to start?
So I would rather get a good TD on this, and that would really help me to plan for the strategy, because this is a sort of a blister proximal to the aneurysm, and definitely which one has bled is very difficult to comment here.
Yeah.
So we need to address both the things.
Yeah.
And as we know, clipping of this small blister one is definitely a challenging situation.
Yeah, definitely an atypical, not a bifurcation aneurysm.
Yeah.
And I did think that this aneurysm was the ruptured one, and it wasn't at a branch point, and it was distal to the bifurcation here.
Absolutely.
But there was also some little lumpy, bumpy irregularity there, which I noted on the 3D, which wasn't evident. Peter, what would you do with this one? These are the best images I got, is all I got.
So I think it's the larger one that rupture, right?
I think so.
Yeah, so I think the option here is, you either do surgery and see if you can clip reconstruct that, which I think is suspicious here, and based on what the ologist says, this might be from dissection or something. It's not the usual bifurcation aneurysm. The other option, if you think is blister dissecting aneurysm, flow diversion is another option. But the problem with that, of course, is antiplatelet therapy, jailing the other MCA. But the patient has a relatively low grade, relatively small hemorrhage. I think that's
normal
assumption. I think the worry of trying to clip reconstruct this is that you may end up with a hole in the bifurcation pretty quickly once you explore that.
Yeah.
I think then you have to look into bypass options. Once that happens, so certainly if you can explore that, I would have a kind of backup, bypass option in case if that were to happen.
So you would favor surgery over endovascular and potentially a bypass?
Yeah, I guess these are the options. I don't know. I'm just
not sure yet.
I think those are the options. I think flow diversion is perhaps not a bad option for these kind of blister aneurysms. I think if you're going to explore that, you have to be prepared to do bypass. I think this may not be that clippable at the end. So,
Omar.
Yeah, I echo those thoughts. The anatomy here is kind of interesting, right? Like you pointed out, it's not a typical MCA bifurcation aneurysm. Often it's almost like this is like 3 M2s, right? And this one M2 that the aneurysm off is a lot more proximal. You can kind of sometimes understand why these aneurysms form, because they're just at these odd bifurcation points, the flow. I think those little blisters are very concerning. I've started noticing more as I explore elective MCA aneurysm cases. I'm seeing bumps a lot more places as I'm fully dissecting out other M3s, M2s. You kind of, when someone has a large MCA aneurysm, it's not surprising to find these little bumps that we often miss on angio. Even with a 3D, sometimes it just smooths out. Your tech kind of does the reconstruction. You can miss them. So I think you're going to have an opportunity to clip probably that large ruptured one. Although, I sometimes worry that you have to be prepared for, like Peter was saying, reconstruction in terms of flow. If the clip sometimes doesn't sit at the neck or it keeps pinching the vessel closed. And then I'd explore the blister, and while you're there, wrap it or something else. You're obviously not going to be able to put a clip over there, but you probably should leave something protective there, because there's a chance that down the road that's going to become a problem, if it's not the problem itself, which you'll see once you explore it.
Gavin, what would you do?
Yes, I think first of all, put a ventriculostomy, got a little hydrocephalus, get that in line. And I think at Methodist, I guarantee whoever's on call is going to approach this very differently. I think if Orlando's on call, I guarantee Lunas is coiling. I think my two junior partners, they will coil it as well. For me, I need to keep the operative volume up for the residents. I'd attempt to clip it. And I agree. I think those little blisters, I think if you look carefully enough on many of the operative cases, you see blisters around.
Absolutely.
So I think, I think as 3D's got better, imaging's got better, we see more of it, but I see a lot of it in the OR as well. So I would just put ventriculostomy aside, take it to the OR, clip it, but obviously be concerned about this because it's not a branching point. That's how I'd manage it.
So clip, reconstruct.
Yeah.
As best you can.
And yeah, absolutely.
Carlos?
Oh, sorry.
All right, I'm waiting for the other shoe to drop here. This can't be that straightforward. Yeah, no, this has it smells bad. That narrow vessel bugs me. There may be more to this that we're not seeing. I don't think my endovascular colleagues can do anything about those blisters. Right. They might argue about throwing a flow diverter, but the angle I think is too tight for them. So I would explore. I dissect out my STA as a first step just to have it available. Wide fissure split, explore it. If it turns out to be a straightforward, just aneurysm like it looks on the angio, which I don't believe it's going to be, then clip the larger one. Those blisters are prominent enough that in my experience, sometimes you can gather them up with a clip if you're just very careful. Sometimes you can shrink them down a little bit with coagulation or put some cotton on top of them and then gather it all up with a clip. But again, I'm waiting for the shoe to drop here. What else do you have?
No special shoe, but I agree. I think it's, it could go different ways. You could probably coil this or maybe even stent coil it if you wanted to. You probably could not endovascularly treat those proximal things unless you wanted to do a flow diverter across, which I would not necessarily recommend. So I did, here's the STA. I looked for that. It was really kind of puny. So the STA on the AP is that small and laterally, and on the lateral view, you can't hardly see it. So I didn't think an STA was a good option. And so I ended up just doing a side-to-side distally. If you look at the original scan here, those M2s are almost kind of kissing here. So I thought that was a good one. And I don't like the idea of being unprepared and clip reconstructing something like that. If it's a dissecting aneurysm, you kind of have to be prepared to sack it. So I just did the bypass up front, and it looked okay, just a nice side-to-side. The original, the aneurysm is this yellow Cheeto that really couldn't be clip reconstructed, and that was the ruptured aneurysm. The platelet plug is up here. So I put I trapped it, so I got a clip here. I completely trapped the segment. And then this is that little blister off of the back wall that we saw in the 3D. And so I was able to get a tiny little clip, as Carlos mentioned, across it. A little bit surprised that the clip went on just fine, no problem. So I think a nice result, but I think plenty of options endovascularly and surgically. Here's the angiogram. Intraoperatively, you can see the anastomosis side to side, and no strokes or anything postoperatively. I did not try. I didn't like it. I mean, it looked like a little yellow Cheeto, and I think to reconstruct it would have been a little bit awkward and left the dissecting component. So I think probably a high chance of recurrence. Although maybe you say I'd follow it and then treat it down the road if it recurs with something else like a stent or something.
The thing against the dissection, if you look at that lumen, the lumen is the same before the aneurysm and after the aneurysm. All the dissections I've treated, there's definitely a discrepancy between the there's a little bit of narrow.
It's not showing up too well, but it is slightly irregular. And that segment is not quite normal. But I agree with you. When you look for those dissecting fusiform aneurysms, you almost see it narrow right before the aneurysm very frequently. So
did you explore at least see the aneurysm first before the bypass, or you just went ahead and did the side to side?
I had seen the base of the aneurysm. In fact, you can't see it here, but I got my temporary clip really close to it. So just beyond it, but I didn't expose the dome of it. Yeah. So a nice little case. Case 2. This was an interesting one, and these are kind of some weird cases I just wanted to do for fun. This is a 20-year-old who presented neurologically normal in the ER, has a gunshot wound from a shotgun to the left side of the neck. And you can see his common carotid run there on the CTA with all the shotgun pellets. So he's neurologically normal in the ER, gets a head CT scan, and we see that. So there's one shotgun BB in the head, and we weren't sure how that got there because he had no cranial injury. So it was a little bit bizarre. But because of this pellet in there anyway, we took him to angio to see what was going on. Here's his neck run again. And he's missing his superior division. So anyone have any idea of what happened here? No, just that day.
Did the pellet really enter the common carotid and fly all the way up?
That's right. Yeah. So here's just showing no flow, superior division backfilling from the PCA, and there was a tiny little bump on the common that presumably
I've not seen
the BB went in and then floated up. So now this guy's neurologically intact. I did this actually an awake angiogram, and because he was doing fine. So what would you do for this guy? Then what would you do?
How much? What was the time of presentation? Like?
Just 2 hours ago. He just got shot, came to the ER.
No deficits.
He's sitting there talking to me. I'm doing an angiogram saying, hold your breath, hold still, don't breathe, don't move.
So there's no cranial no, nothing else. This is, you sure it's embolic?
I'm sure, yeah.
John, this is not your practice.
Yeah,
My
yeah.
More like these two guys practice.
That's right, yeah.
This is
As per the, I would add, as per the guidelines, it is clinically absolutely normal.
Normal.
Yeah, there's no deficit and
4 hours from gunshot.
Except for the
take it out. Take what and not endovascularly. You'd be open surgical removal.
So well, I mean, if it's really an embolic thing, I'd first try endovascular. Just try and get a stent and see.
Try
it.
Engage an aspiration catheter. Yeah, I thought about that.
Peter, I mean, you have other rounds to see how his collaterals are, like how's he feeling?
I mean, I didn't do a CT perfusion, but you can see here that there's some, PCA peel collaterals coming over the side there. So I mean, you've got to decide, wait for this guy to crump overnight.
I would just leave it.
You would leave it.
The guy's intact. I mean, the guy's intact.
He's normal.
You have nothing but to make him worse.
Explore his neck and put a stitch where the hole is.
But that's a good point. I mean, that was the first thing I was thinking of is first of all, there's a hole in the carotid. You know that there's there. And so the repair of the carotid should be considered because you never know when that's going to be a blowout pseudoaneurysm or anything like that. Now,
correct.
You could do it open or endovascular repair, covered stent, whatever. So I do think that's a serious consideration. But I mean, you have someone with let's call it a large vessel occlusion, and I think you got to have good demonstration of collaterals. I don't know if there's a penumbra there or CT perfusion was.
We did not do a perfusion, just the angio. So I'll skip to it. I decided to take him. I did an open cranie here for this. I didn't try an endovascular because I didn't think a stent retriever would grab it. I didn't know if an aspiration catheter would engage and pull it out, but it was an interesting case. I'll just play this here. So you can see the bullet lodged in the superior division. This is the ICG. You can see the ICG filling. Here's the bullet. And then a delayed fashion, you can see there's some collateral flow. So that was why he's still doing okay. Anyways.
So you didn't need to be there.
I mean, it's arguable. Anyways, it was surprisingly wedged in there.
Agreed.
Yeah, I agree.
Yeah.
They're not busy enough operatively to do this. How do you understand?
Yeah. Anyways, an interesting case, just sewed it up. You guys have seen this stuff. And I'll skip to the superior division. There it is. Looks good on the intraop. And as typically people who are subjects to gunshot wounds, they don't show up to follow up. Do I have 2 more minutes? I'll show one last interesting case. This is a 72-year-old who presented with a PCA infarct. We see these all day. He got imaging CTA of neck of the head, and he had this foramen transversarium osteophyte. This is actually 2 weeks ago, and so the presumption was that he had a vertebral artery stroke from the occlusion, and the other side was nice and healthy. So he was treated with aspirin and Plavix. He actually got an angiogram during that same evaluation. And yeah, that's right. The ACDF was chronic, but the vert was out, completely out. So we didn't have to do anything. Treated with aspirin Plavix. Comes back to the ER 6 months later, and now has a new left-sided stroke. So neurology is calling to say, you want to open up the foramen transversarium. What would you do now? Also the question is, why is he having recurrent strokes? Here's it gets repeat imaging. That vert is still occluded. So, what would you do with this management? It's kind of an interesting case.
I would do an angiogram.
Repeat angiogram. What would you look for?
The status of the vertebra at the foramen.
You would document that it's still occluded, make sure it doesn't have some trickle of flow or something. Yeah, that's what they wanted me to do. And I was like, we've done 2 CTAs and an angiogram. A little bizarre. I ended up doing the angiogram. Peter, what would you do?
Do you have any intracranial pictures?
Nothing other than what I showed. The vert from the left side fills beautifully. No athro, nothing like that. I have one coming up. Yeah.
You do head turning as well?
I did not. So that would be, my chief resident said, Dr. Blackburn, maybe it's opening up when you turn the guy's head. I said, what are you talking about? 2 CTAs occluded, 1 angiogram completely occluded. But okay, I tend not to say no to angiograms if it's possible that something's wrong because they're pretty low risk. So that's a good question. So maybe the theory in your case is that it opens up.
Because if the vert's filling well, it fills the pica on the right side as well.
Yes, yeah. The other side is filling the pica.
Yeah,
contralateral, yes.
But filling the right,
yes.
The contralateral pica.
Yeah.
So then it's going to be either head turning, but do flexion extension, make sure, because you've got an osteophyte there already.
Yeah.
Maybe something lower down.
Yeah.
And that's compressing when you turn the head.
Well, so I took him back, as you said, and the question was, what should I do some dynamic head movement while doing the angiogram? Here's the left vert, and then here's the right vert. I'm going to watch this. This is the contrast stasis in the right vert, and follow that on this video. It's bobbing up and down, and then I have him turn his head, and then it disappears. I'll play it one more time. So watch it. Here it is, the contrast stasis, and he turns his head that way, and then it completely opens up and washes out. And when he turns his head every time, it actually opens up. So remarkable finding, I think, by dynamic imaging. So now what would you do?
I would go fuse that level, just a single. What level is his spine fused at the moment?
It was 1 level above his fusion, I think, C4.
I'd go from the back.
You do an ACD and fuse it?
Yeah, that's what I do. It's most simple. The problem is we've all done, particularly in Seattle, go inside and do those osteophytes. We all have complications. I do the most simple operation to this guy, old guy, coronary artery disease, fuse the back, you're done.
Omar, what would you do?
Yeah, so that's a great finding. And that even your first angio that you shot, what stood out to me was that it abruptly stopped.
Yeah.
Right.
Yeah.
So if your vert is chronically occluded, you're not going to fill half the vert and it's just going to stop. So even your first angio, that's a warning sign that there's something else going on.
That's a good
this is an awesome finding. I think, this is like almost like your bow hunters, eagle type syndrome. One option is fusing so they don't move their head or that stays stable. You could do a decompression as well of the vertebral artery, ACDF approach, go a little bit more lateral, almost like an anterior lateral type approach. I'm sure you could get at it posteriorly as well, but I've just seen it anterior lateral.
Peter?
I would favor decompression. I think that's the issue there for the embolic phenomenon. I haven't done much.
So that's the problem. I've done a few, and 1 or 2 turn out not so great. So
I'll call you to help.
Every once in a while, a spine surgeon gets there. So
I did none of those. I just sacked it. Yeah, I just sacked it. So easy enough. And let him go home.
You don't have to mess with the plate at all. Just go outside the 2 transverse processes, find the vert above and below. And then you can mobilize the vert away from the osteophyte and drill it to the outside. Not mess with the old fusion.
Yeah, after such spectacular cases, I can go home with my laptop. Yeah, I lost my laptop. Thank you very much for your team as they supported me. I lost my laptop in the plane, and I have reconstructed my presentation. This is not my laptop, but thank you. They made a great team, your entire team. So my case, a less successful case, and I'm not very happy about the clinical course of this patient, which is now, today, admitted in my hospital. But the medical history began many years ago. Now the patient is 59 years old. AVM was diagnosed in the left central region in 1987, when he was 23 years old. There were no history of hemorrhage or seizures, and before the Aruba study, patients were treated, and they sent this patient to Heidelberg for proton beam radiotherapy. We sent the patients to Heidelberg and also to Boston at that time. So this was the first image I can get from this patient. It was a follow-up study from 2006. The patient was, this was 10 years after radio treatment. And this 21 years after radiation therapy. So 2017. This is the angiogram, follow-up angiogram from 2018. The right ICA, but you can see the diffuse AVM of the left hemisphere. This is a posterior circulation, and this is a left circulation, the left ICA, a very complex AVM. What to do? Questions to the panel.
I'll start. So anyway, so for me, I've seen some disasters from radiation long term down the road. So I'd get a functional imaging. You know, we can look at the DTIs, look at the functional cortex, really evaluate that, get the radiation records to see where the dose was given. And once I got that data, I'll make my next decision.
Should we treat such a patient in this
condition?
Yeah.
It was stable.
And the patient's stable.
This was neurologically stable without any symptoms, no seizures.
But
no
there looks like a venous aneurysm there, a varix. And I presented one on Monday. Jock saw it, young 20, or you were there, 23-year-old, saw me 2 months later, rupture. So okay. I would speak to the family. I'd obviously, you want to make sure I always say you can get around an AVM 100% of the time.
You are right.
You cannot repair functional cortex. So I'd want to evaluate his functional cortex.
Okay, you are right. Sure. This patient suffered from hemorrhage. In 2023, he suffered from an intracerebral hemorrhage, separated hemorrhage, and now we have this condition. What to do now?
Well, I still wait for the DTI and functional MRI and see what it is. But you got to treat it. But the question is, so, you know, obviously it looks like it's really close to perilytic area. So, but it may be behind. So the thing about sometimes you could be wrong. So what I do is I'll get a DTI, functional imaging. It's hemorrhage in front, which is going to give you a bank in the front. I do intraoperative mapping. Look at the Cerebral sulcus, do direct motor, and I do take it out. But okay. I embolized before as well.
In 2023, the decision was to embolize the choroidal flow-associated aneurysm. We thought that the hemorrhage was caused by the aneurysm. Yeah. No, there it was he had hemiparesis, contralateral hemiparesis, and he was neurologically not intact. It was later good. I will show you the evolution. So they embolized the flow-associated aneurysm, and this occurred, repeated hemorrhage. This year, May, June, July, with hydrocephalus, loss of consciousness, hemiparesis, and aphasia, to respond to your question. So, bad condition, what to do?
Well, I said, I mean, I'd be pretty aggressive, and but I would still want to repeat the angio. What does the angiogram look like now?
So what we did to send the patient to the probably most experienced endovascular department in Europe, Germany, and they performed a partial embolization of the AVM with, I think, a good partial result. However, the patient suffered intra.
So the one thing is that with these large AVMs that are in inelegant cortex, I try and stage them, both embolization and gamma knife. So for example, if I see a massive AVM in my clinic, I will tell the family, look, I'm not going to cure you today, but we may cure you in 5 years' time. So those cases, I would go inside and embolize the part that's safe and then gamma knife the area that's in the functional area.
But this patient was treated with...
No, just saying, but that's how I do just in general. So, but for this guy, he's keeping on hemorrhaging. I'd embolize him and I would say to the family, he's hemiparetic. He's got, you can take this thing out.
The hemiparesis pre-embolization was moderate. But after embolization, this patient suffered from a pyruvate perforation of the vessel, another intraoperative hemorrhage, ICH, and as you can see here, with blood interventricularly. So the patient was after embolization in a poor clinical condition.
Yeah. So
he recovered now.
Yeah. So, I do both endo and open. And I think that what I am seeing more and more of, and Jacques will probably agree with me, is that a lot of the endovascular surgeons that mainly do endovascular have become very, very aggressive endovascular, get a lot of onyx into the venous system, and this is what you find. So you can't cure. I always tell people, when you embolize an AVM, you got to decide what you want to do. Is this a curative embolization? Is this a pre-radiosurgery, pre-gamma knife? And I see this all the time. This venous stasis. It's gonna, you got to go take it out. There's no ways it's going to stop.
I agree with you. So what happened? Fifth bleeding 2 weeks ago with interventricular hemorrhage, hydrocephalus, external drainage, CSF drainage, and this is the situation now. This patient suffered from more complication, pulmonary artery embolism, the necessity of anticoagulation due to it is a very severe course of this patient, but the family and the patient, they prefer further embolization, and he will be treated in the next 2 or 3 weeks. The same
further embolization.
Yeah.
But that's the thing. I think that all of us, I know there's a more operative audience, and I think, we've got to become more vocal. A lot of us, particularly in Europe, just, embolize.
Yeah.
I was in London. I did spend a year in Akasamoli as part of a resident. And even then it started, it's just, I think that surgery, you must use both. You must be smart. You must be, sympathetic for patients, but surgery is not bad. This patient could have been solved a lot of problems by having it treated properly initially.
I think so, because of the post-radiation changes, it would be challenging to operate definitely. So complete embolization should be aggressive embolization should be the strategy. Maybe we go with the new techniques with transvenous and take it on.
Some years ago, we published a series of previously with proton beam treated patients, and the results are not so good as the non-symptomatic.
Originally, when he was still intact,
yeah,
I would be very hesitant.
It's changed.
I've had patients like this in Boston when I was with Insub Choi, and Insub Choi was very conservative, and we would embolize just when the patient was having some type of symptom or a small bleed, very minimally, just to protect and get them through. And if they deteriorated to the point where, okay, I can't hurt them with surgery anymore, and they're bleeding every other week like you're having here, then I think your hand is forced.
But the aim must be the complete elimination of the AVM. This must be the aim.
We didn't agree with that. We felt that you could not cure this. And so his philosophy, and I agreed with him when I worked with him, was to pick off the part that was dangerous and just let this patient continue on, holding on to their quality of life as long as they can.
Okay, let us come to the second case.
Yes, 5 minutes.
5 minutes.
Whatever is the most important feature.
Female patient, 30 years old, intracerebral hemorrhage, right to occipitally medially located, CT on the left side, on the right side, MRI showing another vascular malformation temporooccipitally. So we did perform angiography, and angiogram showed this complex lesion. 3 AVMs, one occipitomedially located, one fistula-like AVM in the middle, and a temporal-occipital superficially located AVM. What to do? She's symptomatic with hemorrhage.
Can you go back to the CT? What was the blood pattern? The blood. Oh yeah, they are separate. One thought I had is did the hemorrhage kind of separate, compartmentalize the AVM? But they look pretty separate.
It is a very circumscribed hemorrhage. It's not a severe hemorrhage. The patient was neurologically quite good. She came from Berlin to our department. That's the situation.
So I would go for basically surgical option in this. And this looks, the bleed may usually in the first case, and in this case, near the ventricle, the ventricular feeder is the most important thing while you're operating, and that should be taken first. and then get to the nidus and completely excise this.
So this is a very good example for an interdisciplinary approach in a hybrid operation solution. And we can treat such complex lesions in one stage. So the temporomedially located AVM was completely embolized by the neuroradiologists, and they were very enthusiastic and intended to embolize the occipitotemporal AVM also, but they only achieved a partial embolization. So we performed a one-stage interventional and neurosurgical treatment. The temporoccipital AVM was very easy to resect. It was a very superficially located AVM, but the third one was not visible during operation. And also when you perform ICG angiography, you can't see the AVM, which was in the depth. So in these cases, intraoperative angiography, the open skull, you can see here the hooks, the embolized AVM, and you can position it, put a clamp in the region where you suspect the AVM. You can identify the AVM, approach the sulcus as we have seen it before, identify the feeders, and a complex lesion can be cured in one stage. This is the advantage of a hybrid solution. So we published our series with multiple AVMs some years ago, and the take-home message is multiple AVMs are complex. The number of hemorrhagic events is higher than in single one, and so more aggressive treatment is justified in this patient, at least in my opinion.
I just did one the other day, one of the occipital, and then I basically on the cerebellum, I gamma knife the lobe, so it's more of a peel AVM, and